Hello and welcome to our podcast on psychiatric drug therapy and ECT. I'm Katie Beck and I'm an FY2 working in the Oxfordshire Deanery.
And I'm James Kelly and I'm a student at UCL.
Today we're going to talk about antidepressants, mood stabilisers and ECT. Antidepressants are classified according to their mechanism of action. All of them act to increase one or more monoamine neurotransmitters in the synaptic cleft.
So what are the monoamine transmitters?
Okay, there's three, so 5-HT, which is serotonin, noradrenaline, and dopamine. Antidepressants work in different ways to increase these levels in the synaptic cleft, and we shall discuss this.
Okay, so shall we start with the three types of antidepressants?
Yeah, so there are three main types of antidepressants which we'll cover today. That's Tricyclics, SSRIs, and monoamine oxidase inhibitors.
Shall we start with tricyclics since they were the first to be developed?
Yes, let's do that. So, examples are amitriptyline and clomipramine.
How do they work?
Okay, so they work on the presynaptic terminal to stop the reuptake of noradrenaline and serotonin. They also have other effects. They have muscarinic, histaminergic, and alpha adrenergic blockade.
So when would you use them?
You'd use them mainly in depression, but also in anxiety disorders. They can be used in OCD and other things such as chronic pain and insomnia, and even in migraines.
Okay, so what kind of side effects do they have?
They have quite a lot of side effects, unfortunately. So let's go through. They have muscarinic side effects, which leads to a dry mouth, blurred vision, urinary retention and constipation. They have alpha adrenergic effects, so this leads to postural hypotension, sexual dysfunction. They also have histaminergic, antihistaminergic effects, so weight gain and sedation. And unfortunately, they also have cardiotoxic effects, which can lead to a long QT, ST segment elevation, heart block, and arrhythmias.
Okay, so you need to be quite careful about prescribing them, don't you?
You do, because actually they are quite dangerous and overdose. So you do really need to look at your patient's suicidal risk before you consider prescribing them. They also have contraindications such as a recent heart attack, arrhythmias, heart block, and severe liver disease. They're also not advised to be used in mania.
Okay, shall we move on to SSRIs then?
Yeah. Okay, let's just talk through SSRIs. So there's examples are fluoxetine, sertraline, citalopram, and paroxetine.
How do they work?
They work, again, on the presynaptic terminal by stopping the uptake of serotonin.
Okay, so when do you use them?
They're the first line, according to NICE guidelines, in depression and anxiety disorders. They're also used for obsessive compulsive disorder and can be used in bulimia nervosa, and we usually use fluoxetine for that.
They have far fewer side effects, don't they?
They don't have as severe side effects as tricyclic
Okay.
antidepressants, which is why we use them as first-line drugs. However, they do have some, so let's just quickly work through those. So you can have gastrointestinal problems such as nausea, vomiting, and diarrhea. Also, something very important to warn your patient about is they can increase your anxiety and agitation within the first few weeks of taking them. This usually wears off. They can also decrease your appetite and lead to weight changes, so it can either go up or down. You can have insomnia, sweating, and also sexual dysfunction. They can also cause hyponatremia.
Okay, so how careful do you need to be with them then?
Well, you do need to be careful, but they are used quite commonly. The only real contraindication is mania. They can actually make mania worse, so you have to be very careful when using them in someone who you think might have bipolar disorder, and usually you shouldn't.
Okay, but it can cause serotonin syndrome, can't it?
It can. Now, this is actually a very rare thing, but it is potentially fatal, so it's something important for you to know about.
Right. And are SSRIs the only thing which causes them?
Yep. SSRIs do cause them, but actually there are other things like amphetamines, monoamine oxidase inhibitors, tricyclic antidepressants, and lithium. They're usually associated with drug overdoses, and actually, if you use a combination of drugs, it's more an increased risk of getting it.
Okay, so how would someone present with this?
Well, it's quite a wide variety of things that you could see. So you could see altered mental state, agitation. The patient could have a tremor. They could be shivering. They can have diarrhea, and they can have neuro problems such as hyperreflexia, rigidity, myoclonus, and ataxia. They can also be hypothermic.
Okay, so how would you monitor someone?
Well, the most important thing if someone has serotonin syndrome is to get senior help immediately if you think this is a problem. But if you want to be swish, I would also start taking some bloods, do a drug toxicology screen, and do an ECG. They need to be transferred immediately to an emergency department.
Okay, so shall we move on to MAOIs then?
Yeah, so monoamine oxidase inhibitors. One example is phenelzine.
And how do these work?
These are irreversible inhibitors of monoamine oxidase A and B. Now, monoamine oxidase A and B act to break down monoamine neurotransmitters. Therefore, if these are inhibited, you then get an increase in these neurotransmitters and synaptic cleft.
Okay. So when do you use them?
These are actually second line treatments for depression because they do have a severe risk of serious interactions with foodstuffs and other drugs.
Okay, well, one of the examples of that is the Tyramine crisis, isn't it?
That's right. Do you know what the other name is for it?
The cheese reaction.
Yep, good name. Basically, tyramine is broken down by monoamine oxidase. So essentially, when this is inhibited, tyramine levels increase. This leads to a release of the body's endogenous stores of noradrenaline and can lead to a life-threatening hypertensive crisis, causing strokes and MIs.
Okay, so what kind of foods have Tyramine in them apart from cheese, obviously?
Basically, cheeses, as you said, but mature cheeses especially.
Right.
So other things are wine, such as Chianti, and beer. Also, things that contain degraded protein, such as pickled herring, smoked fish, and chicken liver.
Okay.
You also have to be careful about prescribing monoamine oxidase inhibitors with other drugs, such as local anaesthetics, adrenaline, cocaine, and certain components of cough mixtures and decongestion.
Okay, so what are some more common side effects then?
So, more common side effects do include weight gain, dry mouth, constipation, headache, drowsiness, insomnia, loss of libido, and occasionally seizures.
Okay. So how careful do you need to be with these?
Well, there are some cautions and contraindications, which include pheochromocytoma, cerebral vascular disease, severe hepatic impairment, and mania.
Okay, shall we move on to mood stabilizers then?
Yeah. So there are three main mood stabilizers: lithium, valproate, and carbamazepine. We're going to talk about lithium today.
Okay, so how does lithium work?
The method of action of lithium is actually uncertain. Um, it acts. It is believed that it acts to modulate neurotransmitter-induced activation of second messengers.
Okay, it's been around for a while, hasn't it?
Yes, it has actually, and it is and still remains the gold standard treatment for bipolar disorder. Um, it is actually it has good evidence it's actually quite effective in long-term treatment of this, and it has been this has been supported by a number of actually controlled double-blind studies.
Okay. So when do you use it?
You can use it in acute mania, in prophylaxis of bipolar disorder, and in treatment-resistant depression. You can actually also use it with antipsychotics for schizoaffective disorder.
Okay, what kind of side effect profile does it have?
Again, like all psychiatric drugs, it has quite a few. So let's just work through these. You can have polyuria due to the reduced ability to concentrate urine due to ADH antagonism. You can have weight gain, edema, a fine tremor. It can actually actively worsen skin problems such as acne and psoriasis. It can give you concentration and memory problems, hypothyroidism, impaired renal function, and it can also have ECG changes such as T-wave flattening and inversion. It can also cause teratogenicity in pregnant ladies.
Okay, so presumably you have to be quite careful then.
You do have to be quite careful. And lithium is actually excreted by the kidneys. So if there's any form of kidney damage and the clearance of this drug is reduced, the levels will increase and toxicity is a risk. You can also get increased lithium levels with NSAIDs, ACE inhibitors, and diuretics. And antipsychotics can actually increase their neurotoxicity. So you have to be quite careful about co-prescribing. When you write up lithium, you must check your drug chart quite carefully.
Okay, so what are toxic levels then?
Okay, so like it's got quite a narrow therapeutic window. So you really want the levels to be between 0.5 and 1 millimole.
Okay,
It becomes toxic over 1.5 and actually dangerously toxic over 2.
right. And what happens when you get to toxic levels?
Okay, well, you can get GI symptoms such as anorexia, nausea, and diarrhea, and you can also get CNS symptoms such as muscle weakness, drowsiness, ataxia. You can also get confusion when the levels get very toxic, and that can then also lead to seizures, coma, and death can actually result. So you've got to be very careful.
Okay, so what do you need to do before you start someone on lithium then?
Well, earlier I was talking about how it can affect renal function, hypothyroidism. So you would like to check your U's and E's and TFTs to begin with, just to check that your baseline levels. A full blood count is also useful. It would be quite sensible to have a pregnancy test and discuss with your lady about if it's a lady of childbearing age or giving them the drug to. You should talk about suitable methods of contraception.
Okay.
It's also important to do an ECG just to get a baseline because it can change your ECG.
Okay, so presumably you need to be quite careful monitoring the levels, don't you?
Yep, you do actually. And the idea is that you measure the levels of lithium in your blood weekly until you've obtained a therapeutic level and that's been stable for 4 weeks. After this, you can do the lithium levels 3 monthly, and you can do renal function and thyroid function 6 monthly.
Okay, shall we move on to ECT then?
Yeah, so we've talked about psychiatric drugs, and now I think another important thing to talk about is electroconvulsive therapy. So this has been deemed to be a highly effective way of treating depression, but it is quite controversial. What it aims to do is to induce a seizure with an electric stimulus whilst the patient is under general anaesthesia and given muscle relaxants.
Okay, so why would you go for that rather than antidepressants?
It really is for severe episodes of depression that require an immediate treatment. Nice to advise that it shouldn't be used for maintenance treatment, but it should be used as a rapid short-term treatment. So usually it's used for severe depression where the following elements are included. So if somebody is not drinking or eating, if the person has strong suicidal intent, if they have psychotic features to their depression or a stupor, and if there's failure of drug treatment and they haven't been able to tolerate the drugs you've attempted to give them for their depression.
Okay, and its speed of action is quite important, isn't it, compared to...
Yeah, it should act quite quickly, whereas antidepressants sometimes only can actually take weeks to act.
Okay, so when do you use ECT then?
Well, as we just discussed, mainly in severe depression, but also it can be used in other disorders when people have catatonic states or if they have a schizoaffective disorder.
And how do you go about it?
Usually, people have 2 to 3 ECT treatments a week. Depending on the illness and the patient, they have up to between 4 to 12 treatments. Um, Basically, what happens during ECT is they're given a short acting anaesthetic induction agent and a muscle relaxant, which gives them about 5 minutes of anaesthesia. During this time, a psychiatrist applies 2 electrodes to the patient's scalp in either a bilateral or unilateral placement and gives them a generalised seizure for 15 seconds.
Okay, what kind of side effects do you get from ECT?
You can get a loss of short term memory, confusion, headache, nausea, and muscle pains. you can also have the risk of having a prolonged seizure. There are also complications with every anaesthetic, like arrhythmias, and that's why it's important to do a good pre-op assessment before ECT, which includes a history, examination, bloods, ECG, and a chest X-ray, depending on the patient.
Okay, are there any kind of interactions with any other drugs?
Actually, there are. Patients are often on other psychiatric treatments. Some, such as antidepressants and antipsychotics, can make it easier to have a fit or a seizure, but some make it a lot harder, such as benzodiazepines. So it's important to be aware of these medications when ECT is prescribed.
Okay, so how careful do you need to be?
There are contraindications, but these are relative. These include heart disease, so a recent heart attack, heart failure, or ischemic heart disease, raised intracranial pressure, and also if the patient has a high risk of cerebral bleeding, so hypertension, recent stroke, and if in pre op assessment you identify any risk to anaesthesia, you should consider whether or not ECT is the most appropriate treatment.
Okay, so that seems about it, doesn't it?
Yeah, I feel that we've covered all the topics. So that was antidepressants, mood stabilizers, and ECT. In our next podcast, we shall try and attempt to cover antipsychotics and anxiolytics. Thank you very much for listening.